All right. Well, I'm Taylor. I am an acute care nurse practitioner, currently working in the ICU, though I am switching over to nephrology. And we're going to go over renal failure. So you'll have to excuse me because the slides that I'm using are actually notes that I actually wrote myself, so they're sloppy, and you guys can look at them later. And I also might be slightly dyslexic because there's a lot of letters that are either missing or reversed. So this goes over basic renal pathophysiology. Obviously, you have your two kidneys, your ureter, your bladder, and the functional unit of the kidneys is the nephrons. So you have your efferent and afferent arterioles that come in and out of the nephron. Blood goes in, and then the nephron either reabsorbs the materials that we need, or it excretes the ones that we don't. Goes into the collecting duct, and then through the ureter's bladder, and then excreted as waste. Four main functions of the nephrons is your glomerular filtration rate. I'm blind. Tubular reabsorption, so reabsorption of those vital nutrients that we need, excretion, and then or secretion of byproducts that we don't need, and then excretion of waste. This other side to it is a more extensive explanation of the exchange of your electrolytes, minerals, how hydrogen ions get converted into bicarb and vice versa. So an increase in carbon dioxide increases your pH because there's an increase in hydrogen ions. Bicarb reabsorption in the proximal convoluted tubule, which would be over here, is sodium dependent, and then in the distal convoluted tubule, it's chloride dependent. So that's why chloride can affect your pH. You'll have a non-ion gap metabolic acidosis, as if your chloride's not sufficient, or if it's too high, especially, you can have an abnormal bicarb production. So acute kidney injury is what we're going to deal with most commonly in the critical care situation. There's three types. There's pre-renal, intrarenal, and post-renal. So pre-renal is going to be a lot of what we see in our population because they're volume depleted, they're in shock. To tie into what Waylon said, they have abdominal compartment syndrome. So that's pre-renal. It's pushing in on the kidneys, reduces the blood flow, and then they don't perfuse correctly. Intrarenal would be our nephrotoxins, contrast dye, NSAIDs, etc. Certain antibiotics. That's why, like with your vancomycin and those types of medications, you have to watch for peak and trough levels to make sure they're in the right range to not affect the kidney. Prolonged pre-renal issues, especially from shock, will cause intrarenal failure because there's not enough blood flow there. And then your post-renal would be all of your obstructions. So you have a renal stone, prostate enlargement, bladder or cervical cancer. All of those can cause obstruction. And that's the easiest one to deal with because you relieve the obstruction, the kidneys get better. You can see what I wrote here. So investigation of renal failure, you need to have obviously your basic labs, evaluate if your patient's dry. A lot of the patients that come up to the ICU, unless they've come in for excessive vomiting and diarrhea, by the time they get to us or CVU or even PCU, they've been more than adequately volume resuscitated. So continuing to pump fluids into them is not going to fix them. I know we typically target a MAP of 65. Maybe some of these patients need a MAP of 70, 75 for a while to get their kidneys working again. ABG, make sure we're not severely acidotic. And then there's some other things you can look at. Renal ultrasound is really important. Make sure there's not an obstruction, especially if they don't have any prior kidney issues at all. Come in with a UTI, definitely need a renal ultrasound. So CRRT is going to be implemented on a lot of our shock patients. There are some articles that actually demonstrate there's no hemodynamic difference between CRRT and hemodialysis if hemodialysis is done with what's called SLED. So it's a very slow hemodialysis over 6 to 8, sometimes even 12 hours. Types of, or your CRRT machine, you have your free blood pump, which is that's the rate going into the filter there. That'll end up going into the filter. You have your post-filter replacement solution. You have your dialysate, and all of these play an important role in how we manage it, because all of our patients, for the most part, are put on CVV HDF. You have to start there anyway, and then can go back. The modes of CRRT. So you have SCUF, which is literally just hemofiltration. You have continuous veno-venous hemofiltration, which takes more volume than SCUF does, but it's still just hemofiltration. There is no dialysate. Then you have continuous veno-venous hemodialysis, which isn't going to really remove fluid. It's just dialyzing. And then the CVV HDF is what we use, which can dialyze, take out small solutes, large solutes, and do fluid removal. This goes into our anticoagulation for CRRT. A lot of the patients we've had recently have liver failure and are in DIC. So you can't use any sort of anticoagulation. Citrate cannot be used in liver failure patients because they can't clear it. And even though theoretically the citrate shouldn't get to the patient, some of it still does, and they can't clear that. Obviously, if they're in DIC, they can't have heparin. So the best thing you can do is increase the pre-filter rate. So we usually, I'm trying to remember what it's set at, but you can go up to like 2,500 as far as that rate is concerned to keep the filter from clotting off. Then there's systemic anticoagulation, which we would use in somebody who can't have citrate. So let's say a liver failure patient or a liver issue, but they don't have really bad coags. You can use heparin. Somebody with a PE DVT. For these patients, both the ones that I just talked about, they need to have calcium in their dialysate solution. And systemic heparin is going to have a higher risk of bleeding. You can also use argatroban, especially if they have a history of HIT or have developed HIT. And then you have your regional anticoagulation, which would be your citrate. That is supposed to only affect the filter. It basically, calcium is an important clotting factor. Citrate pretty much depletes your calcium. And then we have to give it back post all of this. So it connects to your return line before it gets to the patient. And so you're monitoring your post-filter ionized calcium to make sure that's low enough so the filter's not clotting. And then your systemic ionized calcium to make sure your patient's not hypocalcemic. Those people should not have calcium in their dialysate solution because we're giving them calcium. And then there's some that I've never even heard of, but apparently some institutions use prostacyclines, but that's very rare. Battery is running low. So chronic kidney disease, the main thing that we're going to see in our patients is they either have a diabetic nephropathy or a hypertensive renal failure. The hypertension causes vasoconstriction to those arteries that are going into the nephrons and into the kidney, and therefore blood flows decreased, and then you end up with a slow progression of decreased renal function. Diabetes, the hyperglycemia causes inflammation. Those free radicals that people talk about get produced. That inflammation goes into the nephrons and the kidneys, and then over time, you end up with scar tissue and permanent damage. The kidneys will shunt blood to the only functioning nephron, so those other ones basically atrophy and die, and there's no recovery of that. There's 4 stages, technically 5 stages of renal failure. So CKD stage 1 is there's some renal dysfunction, but your GFR is fine. CKD stage 2, your GFR is like less than 90. There's 3A and 3B, and that's based on what your GFR is. I think the cutoff for those is 20%. Less than 20% is 4. And then if you need dialysis, that's end-stage renal disease or stage 5. Other causes of renal failure, Obviously, you can have an acute kidney injury that turns into a chronic renal failure. There's certain types of vasculitis. So there's an ANCA vasculitis that can cause renal failure. There's glomerular nephrosis, which is a high protein. So you're gonna have a lot of protein in your urine. And then there's glomerulonephritis, which is a lower protein. The cutoff to determine between the two is 30 grams of protein a day. The glomerular nephritis are a little bit more complicated and harder to manage, especially because some of those can turn into a rapidly progressive glomerular nephritis. They're going to very quickly go from normal renal function to needing dialysis. Dialysis obviously doesn't fix the kidneys. It is a temporary support until you can hopefully get a renal transplant if they are a candidate for that. So we're going to go over case studies, which is what I mainly want to focus on. This does require participation. And if you can't hear me, please tell me. I'm still recovering from strep and bronchitis. So we have a 57-year-old female who presents with a 4-day history of shortness of breath, increasing weakness, and lethargy. Blood pressure on presentation is 62/38, heart rate 145, SpO2 73%, and her lactic is 56. Creatinine at baseline is 1.2. It's now 2.4 on presentation to the ER. She was given 2.5 liters of fluid per sepsis protocol, started on norepinephrine and vasopressin. On day 2 of hospitalization, creatinine is 3.9. Urine output is less than 10 milliliters an hour, which really actually isn't the official cutoff. It should be 0.5 milliliters per kilogram, but we typically just say 10. And her potassium is 6.5, and she's got acidosis. Before I go into these questions, what kind of acidosis is that?
Acidotic.
Yes, I know, but what kind? Okay, so it's a metabolic acidosis. Your pH is 7.23. Normal PCO2 is 35 to 45, and elevated PCO2 is going to give you a respiratory acidosis. This is low because they're trying to compensate for the fact that your bicarb is 13, which is low, like 22 to 26 is normal. So what is the patient's diagnosis? And I don't mean the renal failure, like what is her presenting issue? Yep, septic shock. So what is the cause of the renal failure? Is it pre, intra, or
The
post
septic
renal?
shock.
So it's a pre-renal failure from a hypoperfused state from shock. Is there anything else you guys want to know about the patient? Oh no.
Okay. Okay, now we're back on. Sorry about that. Didn't have a microphone on, and we will get started again. So sorry about that.
How do you share the PowerPoint?
It's showing, but she needs to be able to see it.
Oh, gotcha.
Oh, wait, no, here.
Which one?
This one.
You said it was your actual notebook, sorry.
Yeah, there we go.
Okay, hang on, just let me make sure that, yep, here we go.
I'm such a nerd.
And we're back. Okay, we're still on case number 1?
Yeah,
Let me make sure we're still recording.
You don't have to make it fun.
okay. So we'll go back to this. What other information do you want about the patient? So their questions were, how much pressures were they on? We're gonna say that they're still on vasopressin at 0.04 units, and they are on 10 of Levophen. No, that was admission into the, that was on presentation of the year. Their blood pressure is 96 over 55.
Still enough like the sheet monitor. That's the numbers.
Yeah. So our cardiac index is 3.8 and our TPR is 620. So what is it? Yeah, they're dilated. So in septic shock patients, you're vasodilated, so your cardiac output's going to be higher because there's nothing really to pump against. So anything else? They did end up getting intubated and they're on an FiO2 of 55% and a PEEP of 8.
What's their O2 set now?
Better than 73. We're in the 90s. All right, so what's the treatment for this patient?
Antibiotics.
What's the treatment for the renal failure? Let me specify. What is the?
For use, they need oxygen in blood, so keep that map up high and get your pressures and maybe.
So we are maintaining a map between 65 and 70, and they are not fluid responsive. They have a metabolic acidosis. They are oliguric. Their potassium is high. Why CRRT over hemodialysis?
Because hemodialysis is going to involve way longer than this was very slow on, I guess, but.
You do not have to remove fluid with hemodialysis. So what is the?
Shifts some greater, so it causes.
Yes,
You're right.
yes. So the fact that they're already on the pressors that they're on, CRRT is going to be the safer route. So the indications, which was on a previous slide that I should have reviewed for acute dialysis. Where is it? There, AEIOU, acidosis, electrolyte disturbances, particularly hyperkalemia. I can't even read my own freaking writing. Oh, ingestion of a toxic substance. So lithium toxicity, drug overdoses of some sort, ethylene glycol toxicity. Those are all, antifreeze is awesome. Like that needs dialyzed out and your patient will be a nice, lovely shade of a green blue. Fluid overload, so refractory fluid overload. You've given them diuretics. People with an acute kidney injury need higher doses of diuretics. Your 40 milligrams of Lasix is not going to do anything. They might need 80 to 120, sometimes even more. And if they're still not diuresing, then dialysis is the next option. And then uremia. So kidneys don't work, you don't flush out those toxins, you become uremic. You get a uremic encephalopathy, you can actually get uremic seizures. Asterixes, so they're sitting there having twitching and weird movements. And it can cause pericardial effusions. So those are all indications of acute dialysis, whether it's CRRT or hemodialysis. No, it does. It doesn't have to.
But it's have to, then why would you substitute CRT over something which is way slower rate?
Yeah, so that's why I said something about the SLED, which is a slow
Yeah.
dialysis.
Oh.
You can run somebody on pressors, depending on how much they're on SLED, make them run for 8 hours, and they should not have hemodynamic instability. It should be equivalent to CRRT. It's a matter of, yes, it's a matter of being able to have a dialysis nurse at the bedside for 8 to 12 hours. That's not feasible.
That makes sense.
And they're not gonna go sit up in that room for 8 to 12 hours.
No, because none of our patients are gonna be stable enough to do so. Unless, I mean, yeah, even then, like, if they're on pressors, they shouldn't be sitting in the dialysis place for that long, so. All right. So CRRT would be your treatment there. 38-year-old male with vomiting and diarrhea for 3 days, recently traveled to Mexico. Blood pressure is low normal at 100/56. Baseline creatinine is 0.9, now 2.6. Sodium is 117, potassium is 5.3. You have a pH of 7.31, PCO2 36, PO2 89, and a bicarb of 19. Your lactic is 32. So what would be his admitting diagnosis? Gracie, quit answering.
Hypokalemia. Hypokalemia.
So why did he come to the ER? What did he come in for? And vomiting and diarrhea are going to cause, no, what's the basic thing that they're gonna cause? Yes, dehydration, hypovolemia. So he has gastroenteritis because he probably drank the water in Mexico. And he's vomiting and having diarrhea. So what is the cause of the renal failure? What's that? Yep, so dehydration is gonna cause renal failure. You need any other further information on him?
No.
Not particularly, no. He's dehydrated. So your treatment is going to be volume. The tricky part is his sodium is 117. How long has his sodium been low? Don't know. You can think perhaps a couple days, but we don't know for sure. We don't know what his baseline sodium is. So what is the concern there? Hmm? And he needs volume, but we don't want to do what? If you have something that comes in hyponatremic, especially with a sodium level of that range, you don't want to raise it too quickly. The fluid shifts affect your brain and you can get osmotic demyelination syndrome, which is irreversible. And so if you raise it too quickly, you're gonna screw your patient up. So unless you know 100% that it is an acute hyponatremia, which is something that's developed in the last 24 to 48 hours, you can't correct it quickly. So this patient's going to be kind of a challenge because of that. We want to hydrate him. This is a hypovolemic hyponatremia. He has vomited and crapped out all his sodium. And so fluids are going to correct it. You just have to be cautious of how much volume and how quickly you're giving it. You might end up, as counterintuitive as it sounds, having to switch to like a D5 half normal saline so that you're not raising his sodium too quickly. And he will need sodium levels checked every 4 hours. Now, usually when you get into like the 120 range, you're fairly safe, but you still don't want to raise it more than 8 to 10 in a 24-hour period. After that, you're good.
How quick is too quick?
So the goal is 8 to 10 in 24 hours. So let's say this is the sodium and 4 hours later you check it and it's 124 already. You're going way too fast.
Okay.
So you only want to go up 1 or 2 every time you check it, basically.
Okay.
So any questions about those? Okay. 68-year-old female with a history of alcoholic cirrhosis presents with complaints of shortness of breath and worsening abdominal distension. Her baseline AST is 143, ALT 106, bilirubin 1.9, INR or 1.6, INR 1.9, sodium 123, and her baseline creatinine is 1.8. We now have more elevated liver enzymes Bilirubin is up to 2.6, INR is now 3.4, sodium is 114. She's a little on the low side on her blood pressure, but that's not awful for a liver patient. She has significant ascites. Her creatinine is now 3.6, up from her baseline of, what did I put it at? 1.8. Her potassium is 4.5, and there's her ABG. So what is her admitting diagnosis? She is a cirrhotic patient. She has chronic liver failure at baseline. She's coming in with worsening of that liver failure. What is her diagnosis? Yep, acute on chronic liver failure. You can almost,
That she's.
well, that's next, but her admitting diagnosis is an acute on chronic liver failure. You can almost say that she's a decompensated cirrhosis because she's got the significant ascites. Her INR is higher. I didn't comment on the SBP, but that's definitely something to be concerned about. So at a minimum, she needs to be on prophylaxis for SBP. Which is Rocephin, if anybody cares to know. What is the cause of the renal failure? There's two different things going on here. What did you say? So what is that called?
Almost compartment syndrome like this.
Yeah, so it's either intra-abdominal hypertension or abdominal compartment syndrome. Then there's a difference. So you can have an elevated abdominal pressure without it being compartment syndrome. It's still concerning. You need to do something about it. Compartment syndrome, which is what she would technically have, causes that organ failure, the low blood pressure, all of those things. So that would be part of it. And she also may have a component of hepatorenal syndrome as well. I mean, she does at baseline, that's probably just worsening, and then the compartment syndrome made it significantly worse. Any other information you would like to know about this patient? Potassium and sodium are up there. So I touched on her INR. You need to know her platelet count, her fibrinogen. Because what is the treatment for this patient going to be? Immediately. There's other things we need to be doing, but what is the immediate treatment for this patient? You need to get that fluid off the belly. Also, her bladder pressure is 24, which is definitely within the compartment range.
Is her bladder pressure?
So that's your intra-abdominal pressure. To measure that, you have to have a Foley catheter. You hook it up to a system that measures it for you. And you get a number after you sit there for so long. So you instill fluid into the bladder, clamp it off, and then have it hooked up to a CDP monitor. And then it'll tell you what the pressure is.
What's it known? So
Less than 10 is preferable.
good point.
So paracentesis. And what does she need prior to the paracentesis? Albumin is a big one. She's already borderline low on her blood pressure. She needs albumin. Albumin is indicated, is FDA approved, I guess I should say, pretty much only liver problems. So large volume paracentesis or hepatorenal syndrome. Albumin is the choice of treatment for hepatorenal syndrome initially. And then we need to reverse her coagulopathy. So her platelets are 85,000. Her fibrinogen is 160. And then her INR is 3.6. Safe range for a paracentesis is 1.8 on an INR. Mainly because that's the, 1.6 is the intrinsic INR of FFP. So if it's 1.6 or less, it's not going to do anything for you. So she'll need FFP, which needs to be given between 1 and 6 hours prior to procedure, because that's how long it lasts. Platelets need to be given based on the radiologist or who's performing the procedure. Really, if they're less than 50,000, she for sure needs them. And then she should get some cryoprecipitate because her fibrinogen is less than 200 and we're gonna do some sort of procedure. Paracentesis isn't super risky in terms of bleeding, but if they hit an artery, which can't happen, you're really in trouble. So albumin before, drain the fluid off, albumin after. And typically post paracentesis, if you get so much fluid off, it's 1 gram per kilogram. So she would give albumin, will monitor the renal function and the urine output. For hepatorenal syndrome, all antihypertensive should be stopped. Even if they're normotensive, you just need to stop it. Norepinephrine is the first line treatment for hypotension, and then albumin should also be given. Adjunctive therapies include midodrine and octreotide. If the renal failure does not improve, we would move on to renal replacement therapy, and that would be based on their hemodynamics and stability, whether we do CRRT or hemodialysis. So what about the sodium? It should. So cirrhotic patients are chronically hyponatremic, advanced cirrhosis. So a sodium of 120 in these patients is perfectly acceptable. You don't need to chase it. Yeah, it's fine. You don't need to chase it. They have a hypoosmolar hyponatremia due to decreased SVR, impaired effective arterial blood volume. So a lot of that is going to shift into your extravascular space. Impaired renal capacity to excrete solute-free water. So they're not excreting just water, they're excreting their solutes because everything shifted third spacing, basically. Vasopressin hypersecretion. So then what does vasopressin do? It does cause some constriction, but the primary role of vasopressin is antidiuretic hormone. That's what it is. So it will cause you to retain fluid, and these patients secrete more than they're supposed to. So then they're retaining more fluid. Yeah, and then, like I said, sodium of 120 or better is fine for a cirrhotic patient. All right, this is a 39-year-old female who presents with right-sided flank pain, fever and tachycardia. Blood pressure is 120/74, and she has a UTI. Her renal function is much worse than baseline. Potassium's 5. She has a slight metabolic acidosis. Her anion gap is 24, lactic is 28. And CT of the abdomen and pelvis shows an obstructing right UPJ stone with hydronephrosis and perinephric stranding. So what is her admitting diagnosis? I'm deaf, you're gonna have to speak out.
I'm myself.
Okay.
Sorry.
The symptom is, the myocarditis, but
Yes,
that's what I'm only worried about. If I get UTI, and then myocarditis, then puts out the dies.
but she has an obstructing ureteral stone as well. That is not intrarenal.
It's not.
Post-renal. Intrarenal is in the kidneys, in the nephrons,
Oh, okay.
So the pre-intra.
and post.
So you really want always dehydration, you're not taking.
Dehydration, a shock of some sort. It
Right,
doesn't have to be septic. Any sort of shock
right.
would be pre-renal. So this is post-renal from obstructive nephrolithiasis. So do you guys want any further information on this patient?
I don't need to know what to ask.
There really isn't a whole lot. You got everything laid out right there.
Like I'm so out of my element right here.
That's okay.
Like, kidneys nodded. I mean,
Well, the thing with kidneys, though, any disease process will affect them.
Yep.
So, yeah, just there to shake out and just be new babies. And hopefully bring them back.
No, I think this is the most I've learned about kidneys
Yeah.
ever. So I'm just like, you're like, what else is there now? I'm like, I don't even know.
I know so much, I can't know.
Yeah.
All right, well, what is the treatment?
So,
Gracie, stop it.
Yeah, get rid of the. And
What did you say?
also.
Oh, yeah.
So it would be cystoscopy with ureteral stent placement. The whole point of the stent is to open up that ureter so that the stone will pass.
And at this point, that's something they'd always do emergently. You're gonna call them in, you're not gonna see the pass.
The only time in which that doesn't occur is when the patient is too unstable for surgery and they will put in a nephrostomy tube until they're stable enough to go for cystoscopy.
Basically, they would tap the kidney directly.
Right, so
Get that pressure off.
what makes it like super encouraging here? Like what, like, cause you're like, oh, they're gonna do this instead of letting them pass it. What is,
Because they have sepsis and kidney failure.
And then shock.
okay.
Because like they say, stone.
Yeah, like in here,
So anybody who has a kidney stone, that you can have kidney stones without infection.
you know, I get,
You let those pass, but this, because she has an infection, she's presenting as septic because she has fever, tachycardia, and an infection,
right,
and her kidney function is profoundly worse.
okay,
She needs that removed immediately.
okay, so then, thank you.
Mhm. And then the next day, your renal function should be significantly better, not necessarily back to baseline, but that should fix everything. I had a patient who had renal failure because his catheter was clogged.
I was gonna say, you have to kind of, when you're nursing diagnosis, make sure that it, flush that and make sure that's why you're checking your output. It's-
So anytime, yeah, if your patient's urine output has decreased or dropped off completely, bladder scan them
Yeah, we did,
every time. Or just straight up flush the catheter.
And septic patients, especially with UTI, sometimes their stuff is nasty. But like, even after, they've been having it, there's still some sludge in there that can block that off pretty decently. Even-
Because that'll be the easiest way to fix their kidneys, is if there's an obstruction, get rid of it. So,
what you said, though.
all right. This patient has an anion gap metabolic acidosis. Their blood sugar is 273. What other information would you want from that? And why is their anion gap high?
They're like, it's not to go. Oh, wait, I need the right one.
The diagnosis of DKA requires the presence of ketones. This patient does not have ketonuria and their acetone level is normal. So other causes, this is important to know because I've had physicians admit patients with DKA and they were not in DKA. The anion gap is high because of the renal dysfunction and the lactic acidosis. Both of those are going to cause an anion gap metabolic acidosis. All right, last one. Oh, where'd it go? Shannon, what happened?
It's up now.
No, this isn't it. I think I might have added this on later. I'll just read it. Actually, I don't even know if I have it on here. All right, I'm just gonna tell you,
Case number 4?
now,
No.
I added another one.
Okay.
Specifically for CVU. All right, patient presents with a STEMI. They have chest pain, ST elevation. They go to the cath lab and they have an occluded LAD and get a stent. They also came in hypotensive. Blood pressure was like 72/40. Renal function at baseline is normal. They've now got an acute kidney injury. What would be the cause of the renal failure? Oh, we do an echocardiogram baseline. Their EF is 60% and now it's 15%.
Was 16, not 15. Yeah.
They're on a balloon pump. They're on pressors.
Flat.
It's a cardiogenic shock. This patient's in cardiogenic shock. Also, with acute heart failure or any kind of heart failure, you can develop a cardiorenal syndrome. So it's a combination of the two. Cardiorenal syndrome is due to decreased cardiac output. So you don't have to be in shock to develop cardiorenal syndrome. Patient gets weaned off the balloon pump by day 2 and is off of pressors later in the afternoon. By day 3, the patient's renal function has worsened even further. When they came in, they were 175 pounds and now they're 190. So what is the renal failure from at this point?
That's my theory.
Yep, so that would be a cardiorenal syndrome. How would you treat that? Yep, so the heart's not gonna repair for a while, so rule of thumb with anybody who comes in with an MI and then has acute heart failure from that, you give them 3 months, they'll go home with a life vest if their EF's less than 30%. You do another echocardiogram in 3 months. Hopefully their heart function's improved. If it hasn't, that's just it. That's what they're gonna be. They may improve slightly, but the diuretics, you want to get the volume off. They're no longer in shock. You can diurese them. This will reduce your intra-abdominal and renal venous pressures, improving blood flow to the kidneys, reduces RV dilation, which will improve your left ventricular filling pressures and cardiac output. If they're hypertensive, you use a vasodilator. In chronic heart failure and chronic kidney disease related to that, well, chronic kidney disease in general, you use an ACE or an ARB. Not in this population because it's an acute problem. And if your patient's chronically on an ACE inhibitor for renal failure, they come in acute kidney failure. On top of that, you stop those medications. They're only renal protective if there's not an acute kidney injury. You can potentially have a combination of therapy of dobutamine to improve your cardiac output while simultaneously diuresing them because it should theoretically improve your diuresis. If these therapies don't work, then you would do hemofiltration of some sort to get the fluid off. That could be scuff, that could be CVD, continuous veno hemofiltration. Back in the day, we did aquapheresis, but that's fallen out of practice.
Nobody asked about that when it's on the go, or it's suggested that like.
So I'll just have one more question and then I'll be done. Why is an ACE inhibitor or an angiotensin receptor blocker the drug of choice for hypertension and renal failure?
That's what you look at the graphs. It's all about the kidneys and the kidneys controlling the fluids in your system. So that's not like that.
Yeah, so when your kidneys are irritated, they actually will start producing more renin, which will then convert to angiotensin, which then causes more hypertension. So you use an ACE. The ARB is only if you're ACE intolerant, which the most common complaint is cough. And so those are indicated in renal failure and then also in diabetes because diabetes will cause renal failure if it's left poorly controlled for a long period of time. So, questions? Okay, thank you.
Thank you.
Oh, Susan was answering and I didn't even see those. I'm sorry, Susan.
Shoot. I didn't see them either. They're hard to see on my phone. We'll be stop recording.